Hello, my name is Rashida Shah, and today I'm going to be presenting my clinical scholarly project intervention, information about the intervention. And so I'm currently a student, a doctorate of nursing practice student with a focus on family practice. And I'm also working as a registered nurse with a degree in biology and nursing. And so basically for my clinical scholarly project, I'm going to hold an educational seminar to promote diet adherence for adult hemodialysis patients. So basically before going into my project, I just want to provide a brief background. So the definition of adherence. Adherence is basically compliance. So it's basically the level of the extent to which a person behavior, such as taking medications, following a diet, or having lifestyle changes corresponds with the recommendations from the healthcare provider. So when a patient is non-adherent, that means they're not following the recommendations made by the healthcare provider. And non-adherence is common amongst patients with chronic diseases, such as end-stage kidney disease, and these patients are on dialysis. And non-adherence can be intentional or non-intentional, and several patient-related, disease-related, or treatment-related factors can contribute to non-adherence in dialysis patients. So measuring adherence methods. How do you measure adherence methods? There's different ways you can do that, and it's done differently in different studies. You can measure indirectly, such as when a patient self-reports adherence, or there could be direct measures such as counting pills or electronic medication event monitoring systems, and to see if a patient is just adhering to a dialysis session. There's also other measures such as checking weight gain or biochemical parameters, which include phosphate and potassium levels. So the American Kidney Fund, in order to measure factors contributing to non-adherence and possible interventions to improve compliance, the American Kidney Fund conducted a 33-question survey that was distributed around the United States to dialysis patients. And then more than half of, or 58% of patients reported non-adherence to the diet recommendations. So one of the most commonly reasons for non-adherence was not being educated well on the diet, having a strict diet, and finding it difficult to follow when you're dining out. And what also was common amongst the non-adherent patients was eating or drinking more than suggested. And 58% of patients ate or drank more sodium, phosphorus, potassium, or protein than suggested. So for my clinical scholarly project, in order to have the educational seminar, I will have stakeholders, and these include the registered nurse, nurse practitioner, dietitian, and case manager. So the role of the stakeholders vary depending on their current position. So the registered nurse, which will be me, also the DNP student, I will be the one who will organize the educational seminar and create presentation and pamphlets using printing the pamphlets and using a projector and screen to have PowerPoint presentations, which will include videos and images. And it will be done in both Spanish and English. The presentations will reinforce the diet education, benefits, consequences, and what the normal limits are, restrictions are for the diet. And I will also teach patients about the MyPlay app, which is used to manage diet by having patients input their daily intake. I will be working with the healthcare providers and also to manage the patients and to see if patients are improving, and making sure that patients are adhering to the diet. I will record and collect the data, and then also I will distribute an exam for pre and post exam along with the survey to the patients. The nurse practitioner will communicate with the patient in order to create an individual diet, and then educate the patient on the treatment plan, and follow up and assess whether patients are following the educational plan along with their lab values, and see if they need any adjustment in the diet or medication. The dietitian will also monitor the patient's diet and reinforce diet adherence, educate the patient about the importance of their diet, and assess the labs of the patients to see if there needs to be any adjustments. And the case manager will oversee the patient and nurses and also assess patients' labs daily and communicate with the nurse practitioner or the other healthcare team to see if patients something needs to be changed for the patients in order for them to adhere to the treatment. The patients will be adult hemodialysis patients. So over the age of 18, there will be a total of 30 patients, and they will participate in the educational seminars. They will take a pre and post exam that will assess their knowledge that they have obtained and the knowledge they had prior to the sessions, and they will follow the recommended diet throughout the 3 months to see if if the education helped them improve their adherence. So for the foundation of the CSP intervention, when deciding how to help improve adherence amongst patients, I looked up some common factors that contribute to non-adherence, and these include level of education, low health literacy, and language barriers. So level of education has also been cited as a detriment in adherence behavior in chronic illnesses such as chronic kidney disease. Low education has been found to cause decreased adherence due to poor correlation with knowledge of disease and treatment. Knowledge appeared to be a chief facilitator of positive adherence to fluid restriction and accurate self-assessment. So that plays a role. Not knowing about your treatment, not knowing about your disease and the benefits and consequences related to adherence can affect whether a patient will adhere to a diet and the prescribed treatment. Also, low health literacy has been reported in dialysis patients, and this factor combined with regimen complexity may contribute to non-adherence. Those with low levels of health literacy find it difficult to follow instructions or care on how to care for themselves or to adhere to treatment regimens such as taking their medications. Finally, language barriers. 33% of professionals cited language barriers as a reason that patients missed their dialysis treatment. And 24% of providers reported that language barriers prevented kidney patients from asking questions about their treatment. This reveals a need for improved, culturally relevant patient education in multiple languages and ensuring that providers have the time and resources that they need to adequately support patient adherence. Moreover, I found 4 studies that showed how educational seminars have shown to improve patient adherence. So first, a systematic review and meta-analysis was conducted to evaluate different interventions that were used to improve adherence. There were 36 randomized controlled trials that were analyzed, and interventions that were conducted included educational, counseling, and psychological. Educational and cognitive interventions were most of the studies that were analyzed, and the education also took part in almost all the studies. Weight and blood pressure were used to evaluate adherence to the fluid and diet recommendations. A majority of the randomized controlled trials showed improvement after the educational seminars were done, and measure changes like in phosphate and weight gain were most commonly reported outcomes, and both showed significant improvement in the meta-analysis. In addition, the American Kidney Fund, that survey I mentioned earlier, they also found that 56% of patients preferred printed health materials and using planners to help them adhere to their diet and medication treatment. And the younger patients also were interested in using mobile technology and apps to help them adhere to their treatment. Another study was conducted, which was a quasi-experimental study, and it tested the adherence to fluid and sodium restriction knowledge. So 45 patients were analyzed for 6 months. There were 3 educational sessions that were done for 30 minutes, consecutive sessions, and the educational intervention led to increased adherence. Another study that was done was 20 to 30 minutes of additional education was added every month to a patient's education. And there were 32 patients in the experimental group and 31 in the control group, and a monthly blood sample was drawn. After the extra education was provided, it was found that patients had increased knowledge and decreased phosphate levels. So the educational needs that the stakeholders will have to have and the patients will vary. The stakeholders will need to be educated on the purpose of the educational sessions along with the prevalence of non-adherence. So they will need to see why it's important to hold these educational sessions and the benefits that will result as patients adhere to the diet. And the stakeholders will also be told the role that they will play in this during the educational seminars. They will receive weekly emails indicating progress and findings, and they will also receive an outline of the intervention, the methods, and outcome measures that will be done during the project. The patients will receive education on diet adherence information, the benefits of adhering and the consequences of non-adhering, fluid and sodium restrictions, weight and blood pressure measures. So they will be told what the normal range that they should be obtaining each daily for fluid and sodium and what their weight and blood pressure should look like. And they will also be educated on the MyPlate app, on how to use the app to input their daily intake in order to manage their diet. So this is an outline of the intervention, the research design. So the study that will be done for the clinical scholarly project will be a randomized controlled trial. It will be done in 3 months, and there will be 4 educational sessions. So 3 educational sessions will be every week for the first month, and the final educational session will be in the final week of the final month. There will be 30 adult hemodialysis patients, 15 in the experimental group and 15 in the control group, and they will receive hemodialysis 3 times a week, and they must have had dialysis for the past 6 months in order to participate for the study. So as mentioned, there will be 3 educational sessions and 1 follow-up session. Each session will be 3 hours long. The information will be provided in English and Spanish. The session will take place on the first day of every week for the first 3 sessions, and then the final day of the final week for the follow-up session. The stakeholders will be present for 1 hour in each session. There will be a pre and post exam. Pre-exam will be done on the first educational session, and post will be done on the final day. And then during the sessions, there will be presentation and pamphlets. And for the first and final session, blood pressure and weight will be obtained for each patient. There will also be a MyPlate survey that will be done at the final session, and this will just receive feedback from the patients on how the app was able to help them manage their diet and the level of use that they had, and if they found it beneficial, if they found the MyPlate app beneficial. And then there will also be a meeting with the stakeholders for 10 minutes during each session, just to go over what's going to be covered and what if there's any changes in the patients and if there's any information that needs to be known. In order to see if the intervention was successful, there will be a pre and post exam, and it will assess their level of knowledge. There will be blood pressure and weight checked before and after the sessions, and a survey will be done at the end. This is how the exams will be structured. There will be 30 questions, and points will be given based on how correct the answers were. There will also be a 10-question survey for the MyPlate app, just to see their level of use and if they found it beneficial. This is a chart with the cost and benefit analysis. It tells the salaries for the stakeholders and the amount of time they will contribute to the project, along with the equipment cost. And the final benefit will be $3,571.20 based on $50 per session per patient. And then these are the references used.